Slide. Good afternoon, ladies and gentlemen. Thank you for inviting me. Absolute pleasure to be here. This is where I come from, only dedicated liver unit in our country. Why AI in MASLD? Approximately 2 billion people have MASLD, and it's notoriously asymptomatic, and majority present with the decompensating event even in the developing countries, and therefore there is a great necessity to diagnose them to intervene early. AI is changing the landscape in clinical medicine, so why not in MASLD? This is how we diagnose MASLD adverse events now. So what are the problems? Population screening is still not considered cost effective. FIB4 has been very useful for the past 10 years, but it has its own issues like the Asian cutoffs, valid in extremes of age. FibroScan is not freely available, especially in a resource poor setting. It has its own issues like the validity in obese and variability of values with the operator and the machine. And biopsy has its own issues. So can we do better? So what are the questions to be answered with AI? How can we diagnose more patients early? Can we do better than FIB4 at primary care? Can we do without transient elastography, especially in a resource poor setting? And can we reduce the doctor burnout? They won't be able to do FIB4 in 2 billion people. So since COVID epidemic, the global biotechnology leapfrogged during that period to some observers by 7 years. So AI is considered something similar to discovery of antibiotics, next big thing in medicine. So since 2020, publications started appearing in journals on the use of machine learning. We listened to machine learning earlier. Its value in diagnosing and predicting adverse outcomes. In this paper by Chang, they had concluded that machine learning models performed better than the FibroScan, the FIB4, the FASTScore, and then FSScore. And the feature is that they use many more parameters compared to the traditional ones used in FIB4, up to 17, including the BMI, HbA1c, the hypertension status, and the lipid status, and waist circumference, and others. So I selected 3 publications from this year, one from each continent, the Americas, one from Europe, and one from Asia. And in this publication, NG and others concluded this from America using the enhanced data, that it has superior ability to predict high-risk MASH compared to the traditional ones. And the top 5 predictors were ALT, gamma GT, platelets, waist circumference, and age. In this study by McTee and others, on data from Litmus Consortium from 14 countries in Europe, they concluded that machine learning models could accurately predict with high accuracy ranging up to 99%. Then the study that listened few minutes ago by Worm and others also predicted the same, and it's better than FIB4 in ruling out adverse outcomes in biopsy-proven NAFLD. To summarize all 3 studies, with machine learning models, we could predict adverse outcomes more accurately using parameters, traditional parameters beyond age, AST, ALT, and platelet count, and using up to 17 variables. And when validated, these are going to be useful, especially in a resource poor setting, and maybe avoiding biopsy, maybe even elastography. So coming back to Sri Lanka, We offer a mixed bag for our patients with MASLD. We have a population of 22 million. Healthcare indices are best in the region. Two-thirds of our middle-aged people have NAFLD on ultrasonography. Very few hepatologists, but plenty of corrupt politicians. Only 2 fibro scanners for the country, and thanks to them, nothing in sight for the next 3 years because of the economic meltdown. But we do offer free transplants for selected patients. So desperately we started looking at our patients, and we did FIB4 score in 363 patients with diabetes, and out of them 33% had FIB4 of more than 1.3 and 8% had advanced fibrosis. And we tried our luck with machine learning, and we also got some good signals in addition to FIB4. Like Dr. Verma mentioned, we had identified 14 variables, and they could predict significant fibrosis with fairly good accuracy, and we are trying to publish this. So not only in advanced fibrosis, and machine learning is probably useful in predicting liver cancer as well, because up to 50% of liver cancers appear in non-cirrhotic livers, and there are now clear guidelines how to screen them when they don't have advanced fibrosis or cirrhosis. And in this paper, Sarkar and others concluded that even in prediction of liver cancer, machine learning could be useful. In addition to that, even AI enhanced ultrasonography would help in detecting these patients. What about AI in ultrasonography and pathology? Is machine eye better than human eye? Answer is yes. With supervised learning, AI, the machine eye will see things that human eye cannot see. So in pathology, there's a major issue with drug trials because of various issues in pathology. And AI and digital pathology is changing the landscape. And this is brilliantly reviewed by Ratsu and others, and they came out with this conclusion. Several digital pathology and AI tools in development will quantitatively analyze the key histological features of MASH and help the drug development. So what about ultrasonography? It will decrease subjectivity, minimize human errors, and it will detect early MASLD and could accurately quantify fat in MASLD, just like CAP in FibroScan and MRI PDFF. Estimating the stage of liver fibrosis may be more accurate than even elastography, and it will help detection of HCC. So I'm going to tell you 2 possible future scenarios where a patient meets GP and general practitioner, and AI app recording the interview with the patient and with the routine investigation, suggesting the GP to refer the patient to a liver specialist. So GP is not typing anything, so-called keyboard liberation for the doctors. Another scenario, if the electronic health records are available, imagine a GP with 10,000 registered patients getting prompts from apps with diagnosis of advanced or significant fibrosis, and suggesting serological markers like ELF and metabolomics in markers like MASF in the future, and just ask them to refer the patient to a liver specialist. So ultimately, ladies and gentlemen, do you think AI will replace doctors? Very unlikely. But AI will definitely diagnose what doctors miss. But it won't be able to offer empathy or feeling of taking being taken care of them. So to summarize, ladies and gentlemen, AI and machine learning methods are transforming the diagnosis of MASLD very rapidly. It should pick up patients with progressive illness more easily, more efficiently, more cost effectively, especially in a resource poor setting, and we should get electronic health records in place before that. Cancers will be predicted and picked up early. Ultrasonography may ultimately pick up fibrosis reliably. Pathologists will benefit from AI, and this will facilitate drug development and offer some free time for the doctors to be with patients and maybe their families. Exciting times ahead, ladies and gentlemen. Thank you very much for your patient hearing.